very essential and important but neglected component of kangaroo mother care, the third component, that is planned early discharge and follow-up. My slide is not moving.
Ma'am, you click on the slide anywhere in between.
Okay.
Now you find the arrow, ma'am, below.
Yes. Yes.
Thank you.
So in this talk, we'll cover what is planned early discharge. How do we plan the early discharge of a vulnerable newborn to decide to send him home? And we will discuss eligibility criteria for discharge for not just the newborn, but his mother and family. And why the KMC infant requires follow-up, the importance of follow-up that's included in planned early discharge. And second part of the talk would cover the follow-up services which are offered and types of the services and how to organize those follow-up services and referrals when necessary. So early discharge and regular follow-up is a third component of KMC, but with that, one has to ensure continuation of KMC in home environment. This is very, very vital. Otherwise, if we don't emphasize on continuation of KMC in home environment, the KMC duration that we achieve in an ICU would be minimized to hardly 2 or 3 hours. So this is very important to ensure continuation of KMC in home environment. So going home is always a time of greater excitement and anxiety for most mothers and families. They are excited to go home, but they're also anxious to go home because they are worried that now the healthcare providers will not be around and they'll have to take care of the newborns alone, of their baby alone. So very thoughtful and thorough discharge planning is very important and very, very essential because we send them with the OAE screen. But it is very essential also to communicate with parents about ongoing risk of retinopathy of prematurity. And this is medico-legally as well as developmentally very essential to communicate with the parents about ongoing risk of ROP. And need to follow up should be reinforced regularly, not just once, because they may come for 1 or 2 times, but it has to be consistently reinforced. And therefore, follow up is very, very crucial because as a healthcare providers, we would love to see how these babies grow, how they develop, how is the nutrition, is immunization proper. So all aspects of well-being of the infant can be taken care of if we do a very proper optimal follow-up. So planned early discharge is the first part of the third component of the KMC, where mother and family members of kangaroo mother care baby, they should acquire some skills which are necessary, not just to provide KMC, but also to provide essential newborn care at home. And essential newborn care may include even whether how to sponge the baby, how to keep the baby, how to feed the baby, how to know that baby is not well. So all essential newborn care, the skills related to baby's well-being is required to be taught to mother and family members. And early discharge would reduce the workload of hospital staff and will make an ICU or SNCU bed available for another needy low birth weight infant. With the planned early discharge, as again and again I'm emphasizing that it's very important to continue KMC at home. And this is early discharge. By that we mean that we do not discharge the baby by one particular weight criteria. We just discharge the baby if the baby is properly getting KMC, the parents and families are properly giving KMC, and there are other factors. So this is not a weight-based criteria, but it is just the proper understanding of the baby's care by family and healthcare provider for the discharge. The discharge may be delayed. It may not always be early if follow-up services are not available or when hospital is very far that the parents cannot come for the follow-up or in situations where home environment is not conducive. Somebody is sick at home or the home environment is not very healthy, then the discharge may be little delayed. And where mother is not fit physically or mentally to provide KMC, the discharge may be delayed. So the eligibility criteria for the baby for planned early discharge are that baby should have a normal vital parameters. We all know that vitals normal means baby is normal and stable. And baby should not be on any parental medication. She can be on oral medications, but not on parental medication. And maintaining temperature in mother's bed for 3 consecutive days at room temperature. This means that baby does not require any NICU source of providing warmth. Baby is maintaining temperature by mother's warmth as well as mother's environment, that mother's room, mother's bed for 3 consecutive days. If baby can maintain temperature in KMC and when not in KMC but with mother, then it is an eligibility criteria for baby to get discharged. The babies who are discharged should have adequate coordination of sucking, swallowing, and breathing. They say that with KMC, this is achieved earlier. The coordination of sucking, swallowing, and breathing is achieved earlier than what is mentioned at 34 weeks. But even the 30-weeker baby can have a good sucking, swallowing, and breathing coordination if the KMC is given optimally. Accepting feeds directly by breastfeeding or by express breast milk with cup, spoon, or paladite. The feeding is very important for the newborn. So if you discharge the newborn who is vitally stable, whose parameters are normal, not on medications, he can maintain his own temperature, has he knows how to take feeds and how to accept feeds by whatever method, whether it is direct breastfeeding or with the cup, spoon, or paladite. And with all this, there is an effective weight gain of 15 to 20 grams per kg per day for at least 3 consecutive days. If baby is showing consistent weight gain, and 10 gram is not a weight gain for 1.5 kg baby. I always say that it has to be 15 gram per kg per day for 3 consecutive days. Then only it is a good optimal weight gain. And if baby shows that, then gets eligible for the discharge. So baby's eligibility criteria involves his vital parameters, being not on medications, good maintaining his temperature and good feeding skills, and gaining weight. So these are the pictures of in-hospital adaptation, that you can see the mother is all the mothers and fathers even look very confident in giving KMC, and they also show the readiness to go home, and you can see the competence. So in hospital adaptation, if it is good, you are assured that at home they will also continue KMC. And then from NICU, you can shift them to the ward where they are with, if in the previous picture, you see this is the NICU environment, and then this is the ward environment where baby is growing well on mother's chest or father's chest, and they are well adapted now with less presence of healthcare providers, and then they are ready to go home. The eligibility criteria for mother is that she should be mentally and physically well prepared. She should be adequately trained and confident of providing KMC. You can see the confidence in the previous pictures. Mother would have adequate lactation. Actually, we say that if mother does KMC, she'll definitely have adequate lactation. There's no way she will not have adequate lactation. One should ensure adequate family support during hospital stay and at home. Most of the times for this very low birth weight infants, initially after birth for first 5-6 days, the family is around. But then after 10 days, 14 days, none of the family members come and mother is left alone in the NICU. So as a healthcare provider, we have to assure adequate family support for the mother throughout during hospital stay, and not just during the stay, but also at home. Mother should not be having any skin infection, particularly on chest, and she should not be on any addiction or any antidepressant medications. So eligibility criteria for mother is physically and mentally well prepared, confident, competent, well-trained mother who's lactating well with a good adequate family support, and she's not on any antidepressant or other serious addiction or medications. The family also has to get prepared for the discharge, not just mother and the baby. Because when the mother goes home, family should be willing to allow mother to provide KMC. They should provide adequate facilities at home for mother to provide KMC in terms of space, privacy, bed, pillows, etc. And they should also help mother in the usual domestic chores and for follow-up visits. And somebody should accompany mother for follow-up visits, and to allow the community healthcare worker for home visits. So the discharge can be linked to the referral linkage with the community follow-up, by community health worker, and she can assure the good amount of weight gain and proper breastfeeding. The family members who are willing to be an alternate kangaroo care provider can be trained suitably to provide KMC at home, and all of them should have knowledge about danger signs in the newborn with the action plan, that when to know that the baby is not well, and then how to help the baby to get baby out of that dangerous situation and bring to the hospital. So in this picture, you can see the mother being very confident doing KMC. You can see the competence. She's emotional. There is a bonding, there is a competence, and there is a feeling of protection. And that's what KMC brings in mother, the behavioral change. Any preterm mother, we always call a baby premature, but we never call mother premature, because with the premature birth, even the mother becomes, the lady becomes mother prematurely. And she needs to have certain behavioral changes for her preterm infant in terms of bonding, in terms of protection, and in terms of lovingly thinking about the baby and feeding the baby. And KMC brings those behavioral changes in mother very smoothly. The screening protocol before discharge should have, now when we plan the early discharge, we should examine the baby from head to toe to detect any abnormality. Again, before discharge, make sure, review all the reports of the investigations, take measurements of the baby like weight, length, head circumference, and chest circumference. And neurologically, baby should be examined for the tone, for the posture, for movements, reflexes, behavior pattern, or any presence of seizures. So, certain measures before planned early discharge, to again summarizes pre-discharge counseling of mother and family with the reinforcement of all the knowledge and skills they will require to take care of the baby at home. You should tell them, you should show them two places. One is the regular follow-up OPD where they should come, and the second is emergency area where if they have any problem, where should they come. And when and where to refer and how to transport the baby in direct skin to skin contact should also be taught. The referral linkage with the community health care worker after the discharge is very, very important, and all the proper details should be filled in the discharge card. So, what knowledge and skills the parents and family should have before discharge? We should teach them correct way of hand washing. We should teach them correct method of keeping the baby in kangaroo position, how to support the head, how to support the back, how the baby should be positioned on the chest, and how the head position to ensure the patent airway. So the correct method of kangaroo position should be taught to the family. The technique of breastfeeding is taught to mother, and also technique of manual expression, collection, storage, and administration of breast milk. How to store the breast milk at home should be asked, and you should make sure that if they have a fridge, then they can store it in the regular refrigerator for certain amounts of time. But if they don't have any facility, then they can use it for 4 to 6 hours. It should be used within 4 to 6 hours. The mother should be taught about how to assess the baby's temperature by touch technique. We teach mother that baby's chest, abdomen, hands, and feet should be equally warm. If the chest and abdomen is warm, but the feet and hands are cold, that means baby is in cold stress, and this baby requires more covering. Baby should be taken away from, if mother is sitting under the fan, she should go away from the draft of air, and the room temperature can be increased. The safe placement of the baby when not in KMC is again very, very important, because during KMC, the baby maintains temperature, but when the baby is not in KMC, where to put the baby, it is to be taught to mother that baby should not be directly under the fan, and baby should not be near the windows, open windows. The detection of danger signs with the action plan, we will see in the coming slides. We will learn about it. And we should tell mother when and where to refer. The mother should come back for follow-up to which places, and when should she be worried about the baby. So the knowledge and skills before discharge are good hand washing, putting the baby in kangaroo position, technique of breastfeeding to the expression, collection and storage of breast milk, assessment of temperature, when not in KMC, how to keep the baby and how to detect the danger signs with action plan. So ensure that mother knows how to daily sponge the baby. You discourage the tell mother not to give bath till baby is 2.5 kg. Mother can just sponge the baby with the warm water. She should also be knowing when to wean the baby from KMC. The weaning from KMC is baby's decision and not mother's decision, and mother would recognize that the baby would kind of wriggle out of KMC position when it is ready to be uh, maintaining his temperature without KMC. So these are certain danger signs that should be translated in local language and given to mother and family, that mother is made aware about how baby is breathing and what is called apnea when baby is not breathing. So mother should get used to baby's breathing rate, and then she should know that if for a while baby is not breathing, which is called apnea. Or mother can recognize any breathing difficulty or chest indrawing. The temperature assessment, we already talked about cold hands and feet. The mother can notice abnormal movements or behavior or convulsions. She's asked and taught to look for the color, and the color inside of the lower lip should be pink. If it is blue, she should be worried. She should also be, of course, any mother would definitely know if the baby is not feeding well or baby is vomiting. And the other danger signs are decreased activity, diarrhea, and hypo or hyperthermia. So all these danger signs are to be translated in local language and should be given to mother and family. There are certain don'ts of kangaroo mother care, and these don'ts are very important to be communicated with the family before discharge. And these are that do not lay baby horizontally in KMC. So mother cannot lie down supine in when the baby is in KMC. She should sit in a reclined position while baby is in kangaroo position. She should not bath the baby till 2.5 kg. There shouldn't be excessive handling of the baby. Once anybody who makes the baby ready and takes baby in kangaroo position should sit at least for 60 to 90 minutes, and it should not be like every 20 minutes the baby is taken in and out of KMC. So excessive handling of the baby is to be avoided. Bottle feeding should be strongly discouraged, and one should not permit any contact with the sick people. These are very important things to tell mother, because otherwise they will not realize that how a sick person contact can be fatal for the baby. So the discharge card should have the clinical history and all the details of management of newborn, but we should also mention the date of starting KMC and weight at that time, with the weight of the baby at the time of discharge and duration of KMC in previous 24 hours before discharge. Any special medicines, if baby is on, like caferate or antibiotics, it should be mentioned in the discharge card. And the schedule for the further immunization should be mentioned in the discharge card and should be communicated with the parents that when they are supposed to come for follow-up and when they are supposed to come for even the specific immunizations. The list of therapeutic supplements like iron, calcium, vitamin D, and folic acid is also to be mentioned in the discharge card. So, this is about a very comprehensive, properly filled discharge card of a newborn when it is prepared for discharge, and then the discharge card is given all the details. This is the picture of continuing KMC at home by mother. This is courtesy Dr. Rekha Udani ma'am. It is her picture, not mine. Madam has a great experience at KEM on KMC. They had a little house for KMC follow-up, and all mothers used to come in a train, local transport, by keeping the baby in kangaroo position, and they were brought to the follow-up place. And then at home also, the KMC is continued. So mother, when the baby is in KMC, can do the minor works like hanging clothes or, stirring uh, the cooking vessel, or they can even read. This is the comfortable mother at home with twins. This is also courtesy Dr. Rekha Udani ma'am and her pictures. The twins mother is keeping both the babies in KMC and reading newspaper and relaxing at home. So to at least summarize for planned early discharge, the important points are that it is combined with the post-discharge continuation of KMC at home, and mother and family members are trained adequately, and parents are explained about the importance of regular follow-up visit. The next component, or the other half of the third component of the KMC, is follow-up visits and care after KMC discharge. So once they are gone home, this was to send them home. Now, once they are gone home and when they come back to you, what care and what examination one should do. So, what is the need for calling them for follow up is to monitor their general well being and adequate physical growth, to assess their neurological, how their brain is developing, how the baby is developing, to detect, even it gives us an opportunity to detect illness at early stages, and when we can initiate proper management and prevent baby from getting serious. The follow-up gives you opportunity to ensure proper breastfeeding and also ensure a proper duration of supplement administration like iron, calcium, vitamin D, etc. And for also compliance of immunizations, the follow-up is very important to make sure that the mothers and helpers all can recognize danger signs and seek prompt care at suitable level. So why the KMC infant needs follow-up is, these are the points that to know their general well-being, their development, their growth, their to detect illness, to ensure feeding, and for compliance of nutrition immunizations. So where should one do a KMC follow-up? Ideally, kangaroo mother care infant should be called for follow-up in the same hospital, so the same healthcare providers can see how the baby is growing. But if that is not possible, any nearby hospital convenient to family with the proper facilities for follow-up can be assigned for follow-up. Now, with the government's help, there are many district early intervention centers. If available, they can have a follow-up at DEIC, and home visits by skilled community health worker, maybe ASHA or Anganwadi worker, if the hospital visit is not possible. In India, what we need is a very good structured home visits. And all the hospitals should, of course, know the proper way of follow-up, but also the home visit should be well structured and well designed and organized. And the community healthcare worker should have those skills to have a follow-up at home. So, how frequently one should do the follow-up? Before 40 weeks of post-menstrual age, if the baby is discharged, baby is to be called twice a week until it is 37 weeks post-menstrual age, and one follow-up visit per week after 37 weeks of maturity. And after 40 weeks, baby reaches the corrected date of birth or due date of 40 weeks, then the baby can be called at 3, 6, 9, and 12 months of age, even up to 3 to 5 years, as per policy of the facility. Our government has a policy of follow-up till 1 year. It can be extended till 2 years, but even it can be extended up to 3 to 5 years. The types of follow-up services could be a regular health checkup for growth, feeding, immunization, and any parental concerns, and special follow-up for high-risk cases for neuromotor, neurosensory, and psychomotor assessment. And one should not forget the screening for special senses, mainly for the vision and for the hearing. So the ROP screening, the need is to be emphasized, and the hearing screening is to be ensured. So the checklist for the follow-up is that when the mother brings the baby for the follow-up, we assess the breastfeeding, how the mother is giving the feeding and how the baby is taking the feeding. Is mother lactating well? Is baby latching on well? Is the mother giving for the proper duration on one side and then only switching to other side? So proper latch, proper position, proper duration, during the breastfeeding is equally important. The second component or checklist for follow-up is growth assessment and monitoring using appropriate growth charts. So there are the Fenton's growth charts, and there is Intergrowth 21. Intergrowth 21 is good for moderate to late preterms, but less than 33 weekers, the Fenton charts are used. And then they can be continued with the WHO charts. The developmental assessment can be done according to whatever screening for development tool that you use. It could be Bailey or it could be any other scale. Griffith's psychomotor assessment also can be used. The illness, if any, then it gives us early opportunity to intervene early and manage the illness early before baby gets serious. The supplement is very important to ensure that their concerns are addressed, and special follow-up for vision and hearing, and the date for next follow-up visit. Important growth in an infant because the head once a week. The length is less reliable than the weight, and it increases more slowly, and that also is to be measured. For the supplements, vitamin D is given 400 according to the recommended daily dose, and it could be given for 6 months to 1 year. Iron can be given from 2 weeks onwards up to 1 year. It can be given. The calcium and phosphorus can be given till 40 weeks of postmenstrual age. And this is mainly for the infants below 32 weeks of postmenstrual age. The screening for vision is the most important screening of special senses of the newborn, and also along with the hearing screen. The ideally ROP screening before discharge or for all the newborns less than 34 weeks or weighing less than 2000 grams. It is necessary even for the larger babies who have required oxygen or respiratory support, or the babies who were hemodynamically unstable. The first screening for ROP should never be later than 44 weeks of age. And early ROP screening is recommended for extreme premature babies at least by 2 to 3 weeks of age, for babies less than 1200 grams of birth weight. The hearing screening is, initial screening is using OAE or automated auditory brainstem response, or one can do both if you have the facilities. And then the first screen is done at 40 weeks of corrected age or pre-discharge. And if the first test is abnormal, then the evaluation at 4 to 6 weeks of postnatal age for automated auditory brainstem response. And if the second test is also abnormal, then audiologic assessment is advised. The difference between OAE and AABR is that autoacoustic emission does not detect auditory neuropathy, for which one automated auditory response. The neuroimaging is to be done at least in all preterm neonates. Otherwise, it could be done if indicated in the form of USG, CT scan, or MRI. The all preterm less than 32 week or less than 1500 gram, the neurosonography is done once at 1 to 2 weeks of age, and the other one is by 40 weeks of age. The neuromotor and psychomotor assessment is done by Infanib, by neuromotor assessment by Infanib at term 3 months, 6 months, 9 months, and 12 months of corrected age. And Griffith could be done for psychomotor assessment at 6 to 12 months of corrected age. So as I said, the neurodevelopmental assessment can be done using any screening tool one has, like TDS or DASI or Bailey or Infinib and Denver. The language and speech development should be assessed at 1 year, 2 year, and 3 years of age, whereas developmental screening is done at 3, 6, 9, and 12 months. The language and speech development is to be assessed at 1, 2, and 3 years of age. Behavior of the baby is to be assessed at and after 1 year of age. The IQ testing at 3 years of age, and ROP screening at 1 month of age. And as I said, that all babies should have ROP screening by 4 weeks of age, and then detailed examination at 9 to 12 months of age. The hearing screening using OAE or BERA or both at 40 weeks, and then 6 weeks or as required. The follow-up USG at 1 month of age is very important, especially for preterm babies. Some babies do require some long-term interventions like medications, physiotherapy, occupational therapy for babies with the motor impairment and hypertonia. So that also can be ensured and the effect can be assessed during the examination while following up the baby. The treatment of seizures and behavioral disorders is to be reviewed. Speech therapy and hearing aids are advised if they need. Ophthalmic treatment, aids, and surgery in case of the concern, and treatment of orthopedic problems, cardiac problems whenever needed. The behavioral therapy is one of long-term intervention for age. So some long-term interventions are not just in the form of physiotherapy and occupational therapy, but they are also in terms of ophthalmic treatment, speech therapy, hearing aids, some orthopedic problems or cardiac concerns, and even in babies having high risk of developing autism, some behavioral therapy and rehabilitation therapies are required. This is a picture of growing babies at the KMC follow-up unit. You can see the tiny ones are now growing bigger. This is a picture of one of our patients whose name was Mansha, and she was born premature and she stayed for like 4 weeks in our NICU. And you can see the very nice, and she, if when we assessed her development, she was ahead of her age, and you can see that in these pictures, and you can see the bonding between mother and the baby. This particular picture I always show because this is to show the power of effect of KMC for bonding. This baby was born birth asphyxiated. His mother died soon after his birth. The baby was on ventilator in our NICU and then was adopted by father's sister. And you can even on follow-up for this baby was asphyxiated and on ventilator with being adopted by the and the mother having died and being an adopted child. So this is a power of KMC for bonding emotion and well-being of the children. And I would say that it's a blessing for babies and children to receive KMC by anybody who is a responsible caregiver. Discharge and follow-up is that KMC must not be an option, but a routine to be included in care of all premature and low birth weight infants with its three components. I'm sure all two components are practiced regularly, that is kangaroo position and kangaroo nutrition. But the third component of planned early discharge and being concerned that we are sending this baby home, how the parents will take care of baby at home by giving skills to parents, by giving knowledge to parents, and calling them for follow-up is very, very essential. And therefore, it is very essential to practice all three components of KMC. The regular follow-up visits and care are important for all babies, and facilities for follow-up visits and care and linkages should be established for these babies. If you have facility, you follow it up at your place. But if you don't have facility, then linkage with other centers and also linkage with the community healthcare worker is very, very important. The follow-up gives us an opportunity for early identification and treatment of not just physical, but also the developmental problems. We can recognize many red flag signs for the development of the baby during the follow-up and can offer early intervention. And low birth weight infant in the longer run. So at least our feedback in our NICU when I was in VS was that the practice of KMC made us all very sensitive and concerned about preterm care at all levels by nurses, residents, doctors, physiotherapists, parents, and family. And it helped create a loving and caring environment in our NICU where not just preterm babies grow, but all of us grow as a human being. And that is depicted very well in this picture. With students who are very loving and caring doctors. This was 800-gram baby. The parents were scared to hold the baby. So the Nikita and Yashvi, two students, they gave KMC or kangaroo position for this baby who was on CPAP. And then the baby was given to parents when baby got stabilized. So the mother is supported not just by the family, but also the doctors, healthcare providers, and everyone around. And that is the pledge we should take, that will support all the mothers, premature mothers, with our wholeheartedness and practicing all three components of KMC. Thank you so much.
Uh, Thanks a lot, ma'am. Thank you very much for everybody and including me. It was very informative, and I felt very nostalgic by looking at the pictures of your slides, ma'am.
Yes.
I'm really thankful to you, ma'am, till my lifetime of practice, because that uh, out of the doctor touch, whatever you taught to us, right now we are applying and we are happily doing it. So thanks a lot, ma'am,
I'm
for
so blessed, Jatin, to have a student like you. Thank you so
yes,
much.
thank you very much, ma'am. I'm more obliged, ma'am. Thank you so much for so nice and precise, informative session on KMC, ma'am. And everybody of us should at least be sensitized about doing it on follow up, because that is the important part. As madam told, we are missing. In follow-up, we are only worried about ROPs and OAEs and weight and BF and vaccination and all the stuff. We are generally forgetting to even ask them whether they are continuing at home or not. So that should be the integral part of our follow-up questionnaires. Thank you very much, ma'am. I'm handing over to Kunal or Shwetal, ma'am, for the conclusion, ma'am.
1 minute. Good afternoon, ma'am. Purvi here.
Yeah, Urvi, so nice
I am
to
also madam student. I am one of the second students after Naisha, ma'am.
so blessed to see you all, Vishal, you, Jatin, no, everyone.
Yes, yes.
I,
You gave
I,
KMC thesis to one of our first year, and from that day onwards, I know we were
yes,
like we started the KMC camping from then.
I know. Pradyuman was the first student
Pradyuman
in
was the first. Yes,
2004.
yes,
We had KMC, and then Jatin was bombarded with two touch interventions, KMC and massage,
yes, yes.
Britam massage, right, Jatin?
Yes, ma'am. But it was a super session. And one message from Miral also. Right now, she is also listening to your lecture, ma'am. And she also felt nostalgic about listening your voice, ma'am. And she remembered all the stuff regarding our dissertation and final science and everything she told me just before a few
I
minutes.
would love to meet you all. Thank you so much. Yeah.
Thank you.
I
Thank
think
you, ma'am. Very nice
I think
lecture.
I think in our residency, I think people know that what is a KMC, but because of the ma'am, everyone know that what is a KFC, kangaroo father care. I think because this is the one of the things
Yes,
that none of the
Vishal.
unit are doing, and only our unit was doing. The kangaroo father care, kangaroo grandmother care, and everything. I think so. That is a
I
great from
know. And I would say fathers are, a very nice and comfortable KMC providers. That is what father comes, regular presence of father in NICU, mother's lactation improves by 12%. Lactation in mother of preterm. So, yeah.
very true, very true.
Ma'am, please unmute yourself, ma'am. Swetal, ma'am.
Yes, yes. Sorry, sorry. That's really a great party time for alumni of VS and a mentor of VS to have an academic party on the platform of NNF Pathshala. Thank you so much, Deepa ma'am. Indeed, it is a pleasure to have you again and again on the platform of NNF Pathshala. One sentence is really very important. Everyone must take home message this. It's not only the baby who is preterm. The mother is also a premature mother, which needs the support. Lot of support is required, and support is not only in the facility. the follow-up support and constant encouragement and support to the mother to continue kangaroo mother care. As Jatin said, we missed out. While in follow-up, we miss all these components. We may ask for breastfeeding, may ask for development, but kangaroo mother care is one of the important component on discharge. Plant discharge is very important, and that message I wanted to convey, and hence immediately after Vani Madam's zero separation session, I have skipped the part of demonstration of KMC, what is actual KMC benefits. We straight away we went to the third session, and that is plant discharge and follow-up, which is the missing link of our care. And that I wanted
Yes.
to emphasize on the month of May, where we are celebrating KMC in a big way to create the awareness. And with my like I just gave a phone call with her some few days back, and Deepa ma'am was ready. That is really great, ma'am. Thank you so much for accepting our invitation and sharing your expertise. Thank you so much.
Thank you. It's a privilege, Shwetal. And I always say Shwetal is a blessing for NNF. The way she's, so enthusiastically working for newborns' well-being and healthcare. It is amazing. So God bless you.
I wish
Thank
my
you so
EBs
much.
are giving same feedback. So all four EBs are there. Monish bhai is also with us. Vishal,
100%, madam.
Jatin. Thank you so much.
100%.
Thank you.
Yeah,
Thank you.
Monish
Oh,
bhai, thank you so much for your hospitality. It was so nostalgic, and it was a memorable trip to Pattern.
Thank you, madam. Thank you.
thank you all.
Thank you.
We can discuss. Thank you. Thank you so much.
Thank you. Thank you.
Thank you, dear
Thank you.
doctors, for
Bye,
sharing
madam.
your valuable insights. I hope you had a seamless experience. So, with all your permission, we are signing off for today. And thank you once again for extending us the opportunity to host the session. So, looking forward to host you again very soon in another interactive session in the near future. Till then, stay safe and healthy, and goodbye to all.
Thank you, Rituparna. Thank you.
Thank you, sir. Thank you, ma'am.
Thank-
So,
thank
we
you,
are
everyone.
bringing the session to a conclusion over here today.